Welcome to the Pancreatic Cancer Action Network's webinar, Surgical Advances for Pancreatic Cancer. My name is Allison Mayoral, and I am a Patient Central Manager for the organization. At the Pancreatic Cancer Action Network, our goal is to give you hope through better resources so you can make informed decisions. Patient Central can provide free, personalized information on many pancreatic cancer topics, including treatment options, as well as lists of specialists and high-volume surgeons. Contact Patient Central at 877-2-PanCAN or email patientcentral@pancan.org. The webinar is scheduled for 60 minutes and includes a presentation followed by a question and answer session, time permitting. The questions that are relevant to today's topic and more general in nature will be prioritized. A recording of this presentation and the slides will be available under the Educational Events page at pancan.org. Now I would like to introduce our presenter. Dr. Herbert Zay is a professor and chair of the Department of Surgery at UT Southwestern Medical Center in Dallas, Texas. He holds the Hall and Mary Lucille Shannon Distinguished Chair in Surgery. An innovator and leader in the field of pancreatic diseases and pancreatic cancer, he has been a practicing surgeon for more than 20 years. Prior to joining UT Southwestern in 2018, Dr. Zay was the chief of the Division of Gastrointestinal Surgical Oncology at the University of Pittsburgh Medical Center, UPMC, Hillman Cancer Center, and co-director of the UPMC Pancreatic Cancer Center. During his tenure at UPMC, Dr. Zay and his colleagues accumulated research and published extensively on one of the world's largest experiences with robotic pancreatic surgery. Dr. Zay has conducted numerous investigator-initiated clinical trials examining novel treatments for patients with pancreatic cancer, and he currently directs a translational research lab. Dr. Zay, I will turn the presentation over to you.
Thank you very much. Let me just switch here. Can you all, just doing a audio check, make sure you can hear me. Okay, good. Well, thanks very much for that introduction. I'm really excited to be here today, very appreciative for the Pancreatic Action Network and all the work they do for pancreatic cancer advocacy. I've had the pleasure to be involved with them since the very early parts of my career, almost 18, 19 years ago when I first arrived in Pittsburgh, and I've watched them grow from a small group to really the national group that they are today, and the kind of impact that they were able to bring to this terrible disease has been really impressive. And so I was quite pleased when they asked me to do this webinar to really share with you my experience for the last 18 years in pancreatic cancer surgery. My goals for today are there listed. Really, what I'd like to do first is just very briefly review the current state of pancreatic cancer, not so much to reinforce what I think you all know, which is that this is a bad disease, but I think it's important to start with that, to know where we are so that we can really see through the future of where we want to be. Then I'm going to discuss the workup for potentially curable pancreatic cancer. I'm going to review the different types of pancreatic cancer surgery and go into some very brief details about what each of those encompass. And then I'll spend some time talking about the role of MIS, meaning minimally invasive approach to pancreatic surgery. And as Allison mentioned in the introduction, I've really become enamored with the robotic platform as the safest and I think the best way to do this. And I'll share with you a little bit about robotic pancreatic cancer surgery and where I think that field is going. And then lastly, I want to talk a little bit about something that's really just started to emerge, which is the role of surgery in advanced disease. And I think that's important to really just touch on, because I think it's someplace that the field is moving and that we should all be aware of. So I think, again, we all are aware of the real problem with pancreatic cancer. This is the 2018 American Cancer Society statistics. It shows that pancreatic cancer, despite not being one of the most common cancers, and in fact, it doesn't even make the top 10 or 12 list for men, It's number 9 for women in terms of the new cancer diagnosis. Unfortunately, it's the 4th leading cause of cancer death in both men and women, and that just reflects the fact that we really haven't made the kind of progress that we need to make in this disease, and that we all are dedicated to seeing if we can make tomorrow better, and really to get this off the list of the top cancer mortalities. What I'm going to talk about today is surgery for pancreatic cancer, but I just want to mention that a lot of what I'm going to talk about is pancreatic adenocarcinoma. Cancer of the pancreas can arise in several different kinds. Adenocarcinoma is the one that starts from the exocrine, meaning it starts from the lining of these ducts. And that's the most common one, and that's the one that when people refer to pancreatic cancer, that's the one that they're most frequently talking about. There are other types of pancreatic cancer, and that's the ones that can arise from the acinar cells or from the cells that sit in between here that make the hormones like insulin and glucagon, and we call those neuroendocrine, or some people abbreviate them PNET. Many of the surgeries that I will talk about today are appropriate for both the acinar cell and the PNET type of cancer. So I just want to make sure that I talk about that. When we look at pancreatic cancer, it's also important, I think, to talk about, and you'll see as I move through the presentation, the kinds of surgeries we do are all really oriented towards the place in the pancreas. So this is the cells that it arises from, and these are spread throughout the entire pancreas. All of these kinds of cancers can arise in the anatomic different areas of the pancreas. Most of them are going to be found in the head of the gland over here, 5 to 10% in the body, and then another 10 to 15% in the tail. And so again, that just sort of sets the stage for later on when we talk about the different kinds of surgeries. You'll see that as a surgeon, how we approach pancreatic cancer and what surgery we choose has a lot to do with what part of the pancreas the tumor arises in. So I want to start by talking about the workup for potentially curable pancreas cancer, and that's something that I think is a changing definition, and I'll share with you a little bit why I think that is. But when we talk about potentially curable pancreatic cancer, I think as a surgeon and somebody to take care of this disease, what I mean is somebody who I think ultimately would be eligible for surgery, as we think that surgery, while it's not enough to cure pancreatic cancer, is certainly really important for us to hit that home run and potentially cure the patient. So we're going to focus that today on the workup for potentially curable pancreatic cancer. And as you'll see, I think that definition is changing somewhat. This is from the NCCN guidelines. So when we have somebody who's suspected of a pancreatic cancer, the first step that we do is a CT scan. If we see a mass on that CT scan, then the next question is whether or not it's confined to the pancreas or not. That's what metastatic disease or no metastatic disease means. So if the disease is confined to the pancreas, then that puts them into that category of potentially curable pancreatic cancer. And that's, as you can see from the NCCN guidelines, where we start to do a little bit further workup for somebody who would be a surgical candidate. And that's what I'm going to spend a little bit more time fleshing out for you. As a practicing surgeon who does about 90% of my practice is pancreatic surgery, how I go about deciding whether somebody's a surgical candidate or not. So the management of pancreatic cancer, a lot of my patients ask me, well, what stage is the disease? And it's interesting because really the stage, as many other cancers, stage 1, 2, 3, and 4, while it has some prognostic meaning in pancreatic cancer, it really doesn't have as great an effect on the decisions that we use to pursue treatment. And so I think the functional staging for pancreatic cancer is really broken down into what I have here. There's what we call resectable disease, and I'll show you a little bit later on what a surgeon means when they refer to something as resectable disease. Borderline resectable, which is a term I'm not enamored with, but the field has incorporated it, and it's become part of our lexicon. So I think it's important for you all to know what we mean by borderline resectable. And then there's the locally advanced and then metastatic. And so when I think of potentially curable pancreas cancer, I really, in the past 18 years have really meant just starting with resectable disease, but now we've extended that to borderline resectable, and even some patients with locally advanced or stage 3 disease are eligible for potentially curative surgery. And again, I'll touch on that at the very end of the presentation of who those patients are and what we think we need to do to try to get them to that point. So how do we define these different areas: resectable, borderline resectable, locally advanced, or metastatic? Well, all of that really has to do with the anatomic relationship to these. This is a picture of the pancreas here, and all of these definitions really have to do with the relationship of the tumor to these two important vessels here. This is called the portal vein, or the SMV, and this is called the superior mesenteric artery. And all of the definitions that we use as surgeons to decide if this is something that we can take out with a surgery have to do with the relationship of the tumor to these major vasculatures. And I think first thing I think you appreciate from this very busy slide is that how complex the anatomy is of the pancreas. And one of the things that you'll hear, I think, both from national advocacy groups like the Pancreatic Cancer Action Network as well as others, is it's so important to have a surgeon who's experienced in pancreatic surgery. I think you can appreciate from this diagram why that is. This is a very anatomically busy area, and it's one that really have to have a lot of experience to safely operate in. So the standard staging CT scan is something called a triphasic CT, and that's really important as well, which is a lot of people will say, well, I got a CAT scan, and they'll come to me and I'll have to reorder it because as a surgeon, we really need to do this thing called a triphasic CT in order to assess the relationship of the tumor to those two major vessels that I just mentioned to you. So a triphasic CT is the fundamental first workup. Some groups in some areas have moved to MRIs, and a good MRI with good triple phase contrast can work just as well, but it really has to assess the arterial and the venous phases in order really to understand the relationship and for a surgeon to make a good decision about which operation and if the patient is a candidate for the operation. This is a classic triple phase CT scan, and when we look at these, again, that picture I showed you of the SMV and the portal vein and the artery, these are those structures in cross-sectional imaging. So you can appreciate what we're looking at when we're trying to decide whether or not a patient is a candidate for surgical resection. This is what a surgeon means when they say something's resectable. That means that the CT scan doesn't show any tumor outside the pancreas, and we see a nice dark band between the artery and this vein, the SMV portal vein. You can see that dark line there. That means that there's a clear fat plane. That means the tumor has not grown into these. It's completely separate, and in the operating room, we wouldn't anticipate any problems separating the tumor from these major vessels. So that's what we've classically meant as resectable disease. A borderline resectable is just what it sounds like. It means that there's no tumor outside the pancreas, but the tumor has grown right up. And you can see here in these pictures, there's a loss of that little fat plane that you saw in the previous picture. So the tumor is abutting or potentially growing in. And one of the things you don't know from a CAT scan is whether it's growing into this vessel or whether it's just touching up against it and pushing on it. So it's really not clear in the minds of the surgeon whether or not that would be something that they could easily get out completely with what we call a negative margin, or you'll hear some people call R0 resection. That means that you just removed the whole tumor without any tumor cells left behind along these edges or margins. And this is a locally advanced, and that's where the tumor has grown completely around. And you can see in this picture here, this is that SMA. You can see the tumor has completely surrounded it. So that's what we would typically mean as locally advanced. You'll hear some people, and I think it's a historical term that shouldn't be used anymore, call locally advanced as unresectable. I don't think that's inappropriate, and at the end of the talk, you'll see why. I'll share with you some data that suggests that even some patients with this locally advanced tumor can be candidates for R0 or complete resections of their tumor. And so I think we shouldn't use the word unresectable, but we really should focus on calling them locally advanced. So when as a surgeon, as I approach a patient who has a CT scan and it doesn't show any evidence of metastasis, and it shows any of those three categories that I just showed you, which is resectable, borderline, or unresectable, what is it that we do then to really figure out how to work them up? And this, I'll share with you some data that I was fortunate enough to be a part of a panel from ASCO a year or two ago, where we had many of the experts in pancreatic cancer around the country get together and really think about what it is that needs to be done for workup of potentially curable pancreatic cancer. And the group started with this, which I showed you, which is we felt every patient should have a CT scan at triple phase. Again, I think it's okay to have an MRI that's triple phase in some centers, but really you need that triple phase CT. We thought an endoscopic ultrasound, which is something that I didn't spend a lot of time talking about, but has become an important aspect of this, because it allows us to get a piece of tissue to know for sure that we're dealing with either the adenocarcinoma or the pancreatic neuroendocrine or the acinar. So the EUS is a biopsy technique, endoscopic ultrasound. We felt everybody should have a chest x-ray, and then this blood marker called CA19-9. That's a protein that the tumor makes that can actually be found in the bloodstream of some patients with pancreatic cancer. It's important to note that not all patients, about 15% of the population, can't make CA19-9. So CA19-9 is not going to be elevated in all patients, but it should be checked in all patients, because if it's elevated, it becomes a very good marker of response to treatment. The second thing that our group felt was important was the functional status of the patient. We really, the surgeries that I'm about to present to you and talk a little bit about are big surgeries, and even with the MIS approach, which the minimally invasive approach, are still fairly significant physiologic impacts on the patient. And so the second thing that the surgeon and the clinician need to consider is how the patient's overall health is, and are they somebody that can tolerate this surgery without significant impact. Discussion of the goals of treatment. This sounds rather generic, but it's really important, I think, to sit with each patient and discuss with them. We know that pancreatic cancer, even in the best of circumstances, is not cured as often as we would like it. And I think it's important to be transparent and honest with our patients, to let them know that even with a successful surgery, sometimes we are not going to cure that disease completely, but we may have other goals, which are to help them feel better during the time that they have, or to alleviate certain symptoms. And I think discussions of the goals of treatment are a really important aspect of every pancreatic cancer clinician, both surgeons as medical oncologists. We felt as a group it was really important. This disease is becoming more and more, and I'll show you some data in a little bit about the multidisciplinary team discussion. I think it's really important to have both medical oncologists, surgeons, radiation oncologists thinking about each patient and putting together a treatment plan that makes sense. And I'll show you why in a little bit. I think having the multidisciplinary team is more important than ever, and our group that met for this ASCO consensus panel felt the same. Pancreatic cancer is a tough disease, as we talked about at the very beginning, the fourth leading cause of cancer death. The only way that we're going to make progress is to do clinical trials. And so our group felt it was important to let people know that we thought every patient should consider a clinical trial, from resectable all the way up to those who are metastatic and not eligible for surgery, that any kind of consideration of a clinical trial should be done. That's the only way we're going to make progress on this disease. And then lastly, our group felt that the patient should meet the criteria for a surgery-first approach. And I'm going to spend a little bit of time telling you what we meant by a surgery-first approach, and why, truthfully, as a consensus panel, most of us felt that moving away from a surgery-first approach is probably the direction that pancreatic cancer treatment is going, and that only a small number of patients should really consider surgery-first approach. So what do we mean? What are the criteria for a surgery-first approach that our team put together? Oops, I just had to freeze there. There we go. The first was I've mentioned before is that we don't think that surgery is appropriate for anybody who has tumor someplace outside of the pancreas. That the patient's functional status must be appropriate for major surgery. They have to have the physiologic reserves to undergo the surgery and recover. If you can't afford to take one step back in order to get 2 steps ahead, then we won't have helped you with the surgery. There can't be any evidence of a tumor involvement in the major vessels. And that sort of eliminates those second 2 categories, the borderline resectable and the locally advanced, from a surgery first approach. That doesn't mean that surgery isn't appropriate at some point during their care. What I'm talking about now are those patients who should consider surgery as the very first treatment modality in their care. And we, as a group, felt that those patients should really be only those patients that have absolutely no evidence of major vessel involvement. So that would include that first group that we historically defined as resectable. And then lastly, we thought that that blood level, that CA19-9, should be supportive of a potentially curative disease. In general, we thought that was less than 1,000. That's pretty important because even if the CAT scan shows that all the tumor can be removed with a surgery, a CA19-9 that is up over 1,000 generally suggests that there might be seeds someplace else that we cannot see on the CAT scan. And so a surgery to remove only the part you can see may not help that patient as a first modality. And it may be a better approach to treat the whole body first. So our group felt that that was the last criteria that we wanted to include for a surgery first approach. So let me just spend a couple of minutes talking about why consider chemotherapy before surgery, because I mentioned that we do think that surgery is an important part of any curative approach to pancreatic cancer. So why not just run in and take out the tumor first? Well, this is a paper that was published a few years ago out of Memorial Sloan Kettering, where they looked at survival after the Whipple. So I mentioned the head of the gland is the most common place for pancreatic cancer to occur, and I'm going to show you a little bit about what a Whipple operation means, or a Pancreaticoduodenectomy, in a little bit here. But this is the most common surgery done for pancreatic cancer. And what they looked at Memorial was the survival just from the surgery and then the survival from the disease. And what they saw was that the survival from the surgery was getting much better over the last 3 decades. The blue is the 80s, the gold is the 90s, and the green is the 2000s. Saw a significant improvement in surviving the 30 days after the surgery, 90 days, even the 1-year survival. The length of stay got better, so patients were staying in the hospital less. So clearly we had made major advances in the last 3 decades at making pancreatic cancer surgery safer. But the sobering part of this paper was that the overall survival from the disease in the last decade, where we were seeing better survival from the surgery, really hadn't improved. So the question is why is that? Well, it's clear that while surgery is important, it's clearly not enough. And there's been a few papers since this one to kind of suggest why that may be the case, and considering chemotherapy before surgery might be the first best approach. This paper out of Johns Hopkins looked at all the patients who had the Pancreaticoduodenectomy at that institution over a 2-decade period. And what they found were that patients who had a complication and then never went on to receive their adjuvant chemotherapy, meaning chemotherapy after surgery, had significantly decreased survival compared to those patients who had no complication after surgery and went on and got their chemotherapy. And that's not surprising because we know that chemotherapy is really important. But what was sobering again about this paper is that only 54% of the patients who had that open Whipple there at Johns Hopkins ever received adjuvant therapy. That means 46% of the patients didn't recover sufficiently from a physiologic standpoint to go on and get chemotherapy after a potentially curative surgery, and that showed that their survival really was not as good as those patients who didn't have surgery. That same sort of trend was also reported from MD Anderson, where they showed that patients with neoadjuvant therapy first versus, meaning chemotherapy before a surgery, did better than those patients who had no resection and no chemotherapy. And so again, this basically stresses this idea that if you have a complication after this big surgery and you don't recover enough to get your chemotherapy, that you maybe not have been benefited from having that big surgery. So we, as pancreatic cancer surgeons and clinicians, really need to think hard about how can we improve survival from pancreatic cancer in 2018. And I based on the data that I've just shared with you, I have drilled this down in two major things that we can do, I think. I mean, there's lots of research that people are doing to come up with new chemotherapies and new treatment modalities and immunotherapy, and those are all super important. But there's two simple things, I think, based on the data that's out there that we could do. And the first is we could change the sequence of treatment for most people. I think we can give them chemotherapy first. The data is suggesting that's really such an important part that we shouldn't minimize how important chemotherapy is and recognize that most patients after surgery are maybe not even getting to their chemotherapy. So we could fix that by giving them chemotherapy first. And that would perhaps even allow us to incorporate new chemotherapy regimens. The other is we could try to make the surgery less morbid, meaning even though we've done better helping patients survive the 30 days and 90 days, the mortality, meaning the mortality rate from the surgery is quite low, they still have a fair number of complications. And so if we could do something to make the surgery less stressful, then perhaps more patients would go on and get that needed chemotherapy. And that's where my own efforts with robotic surgery were really focused. So I think those are the two things that, very simple, common sense things based on the data that we could do to start to improve survival. So I've shared with you first where we are with pancreatic cancer, and we know it's a tough problem. I've shared with you how, as a surgeon and as a pancreatic cancer clinician, I approach the patient in terms of what information I need to know if this person is potentially curable and somebody who we would perform a surgery on. I shared with you the CT scan, which is the real crux of the first piece of information that every surgeon needs to know. But I also shared with you the other factors that are important to consider: the overall status of the patient's health, whether or not their CA19-9 is elevated, are also really important things. And I shared with you my own personal bias, and I think where the field is moving across the country is the idea that we should be thinking more and more about delivering chemotherapy before surgery as a means to make sure that most patients get both treatment modalities, meaning both surgery and chemotherapy, which we know is important. I'm going to spend the next few minutes really addressing the types of pancreatic surgery, and this is really a 30,000-foot overview. I can't go into all of the risks, benefits, and nuances of this, but I want to give you a flavor of what are the kinds of surgeries that surgeons use to treat pancreatic cancer. And of course, all the other cancers, the PNETs and the acinar cells as well. So how does a surgeon decide which operation? It really comes down to, as I mentioned earlier, where in the pancreas does the tumor start? Does it start over here on this side, which we call the head of the pancreas? And that area is what we would use to treat with, it's commonly called Whipple. It's a Pancreaticoduodenectomy, but it's such a long word that most people refer to it as Whipple because Dr. Whipple was one of the first surgeons to perform this safely back in the late 1920s, 1930s. If the tumor arises in the body or the neck or the tail, then that's called a distal pancreatectomy. Distal is the term for the tail and the neck and the body of the gland. So that's as simple as it gets. When we first look at a tumor, we certainly assess its relationship to these major vessels. And once we've decided that we're going to perform surgery, we just really look at this graph and in our minds ask, is this somebody who needs a pancreaticoduodenectomy or a Whipple or a distal pancreatectomy? So again, the pancreaticoduodenectomy is the most common surgery performed. Most people refer to it as a Whipple for Dr. Whipple. This surgery removes everything that's in this purple here, which is the duodenum, the head of the pancreas, a portion of the bile duct, and then of course the tumor and a bunch of lymph nodes that sit all around the tumor. So this is what it looks like when it comes out after the Whipple operation. And this is really how it is. A lot of my patients ask me after the operation, or the family says, well, how big was the tumor? But what you can see here is the tumor is buried here in the head of the pancreas. And so we never really see it during the operation. We take out a healthy piece of tissue around it to make sure that we don't actually get into the tumor at all. And then what you see here is also after this Whipple, we have to reconstruct things. I mean, we have to sew three things back together: this bile duct, the piece of the stomach or the pylorus, and I'll talk a little bit about the difference between pylorus preserving and classic Whipple in a minute. And then the pancreas as well has to be re-sewn back together. So it's a complex operation. And when you have a complication after this, it's usually related to one of these three new connections that the surgeon has to make. The most troublesome one is the connection to the pancreas. It sometimes can be soft in some patients, and so it doesn't hold the sutures sometimes very well. And that's where, if you have some, just like plumbers who put two pieces of pipe back together, you can have some leaking from this. So oftentimes surgeons will leave drains so that fluid from the pancreas doesn't build up and cause problems for the patients. But that's the most common complication. The second most is probably related to this connection, which is to the stomach or to the duodenum. And some patients will have some slow transit of food from the stomach. We call that delayed gastric emptying. Both of those complications are temporary and they resolve, but they are two things that could slow the patient's recovery and then eventually sometimes prevent them from getting on to chemotherapy timely manner. So what are the types of pancreaticoduodenectomy or types of Whipple? Well, the first is a classic versus pylorus preserving, and I'll show you a picture of that, or there's the extended pancreaticoduodenectomy. The pylorus preserving is really, the difference between the pylorus preserving and the classic Whipple really only has to do with the amount of the stomach that you save. In the classic, you remove about a third of the stomach with the tumor, and in the pylorus preserving, all of the stomach is preserved in a short segment of the duodenum. Now, I will say that there is probably almost 20, 30 years worth of literature where some surgeons have said the pylorus preserving is the way to go, and the others have said the classic. There's even been some what we call randomized trials to try to compare this. And I think if most surgeons are honest, the data suggests that there really is no strong advantage over either one. And most surgeons have a preference of which one they like to perform. And probably that's the most important thing, is that your surgeon's comfortable with the approach that they're going to use. And I don't think that there's any strong literature to support one over the other. An extended pancreaticoduodenectomy means that one of these other things are removed along with the duodenum, the pancreas, and the bile duct that I showed you. So if more than half of the stomach are removed, the colon can be removed, small bowel beyond the first portion of the duodenum, a vascular resection, which I'll talk a little bit more because this is the most common kind of extended pancreaticoduodenectomy. But even in some Whipples, you can have the kidney, liver, or the diaphragm removed. But I would say for extended Whipples, the most common is the vascular resection. It's pretty standardly performed at most major pancreatic cancer centers these days. And again, this has to do with the relationship of the tumor to this major blood vessel. That's what we really worry about as surgeons. It defines the resectable versus the borderline resectable. We can remove a portion of this vein, and this is how we put it back together. There are different mechanisms to put it back together. So the most common extended Whipple would be one that goes along with the vascular resection. There is some literature that suggests that this is just as safe as a regular Whipple. I think that probably a little bit more data suggests that when you do resect this vein along with the tumor, that there's a slightly higher incidence of complications, but not so many complications that it shouldn't be considered or routinely done, but it probably is something that should be considered into the overall condition of the patient to understand that maybe a few percentage points more complications occur when you go ahead and do the extended vascular resection with the Whipple. The distal pancreatectomy is a little bit more straightforward because there's nothing that needs to be recreated. So we just remove the tail of the pancreas, many times with the spleen. And a lot of people ask, well, why the spleen has to come out? It has to do, I think, with two reasons. One, the artery that supplies the spleen, you can see, runs almost right through the pancreas as well as the vein. And then there are lymph nodes that sit all around here and around these vessels that, if you're operating for a cancer, are really important to take out. So I would say for a cancer, either neuroendocrine acinar or for pancreas cancer, a distal pancreatectomy and a splenectomy are going to be the way that most surgeons are going to go. Now, there are increasingly number of patients who are having surgery for benign premalignant lesions or cysts. We call them IPMNs. those patients could be eligible for what we call a splenic preserving, and that's where you peel the pancreas and the tumor off of these arteries and veins to preserve the blood supply. I would say that that's probably less common and should only be considered when there's a benign disease and there's no risk of spread to the local lymph nodes. Another surgery that many people may or may not have heard about is really what I would call an extended distal pancreatectomy. That's really the way to think about it. So I showed you the extended Whipple where we resected part of the portal vein with the tumor. The distal pancreatectomy with en-bloc celiac axis resection, or DPCAR, some people will call this an Appleby procedure, is where we remove the tumor along with this artery here, the celiac trunk. So these are tumors that are unfortunately arise in a bad place, and they grow out of the pancreas and into this major artery that supplies both the spleen, which you can take the spleen out, that's what we routinely do, but this artery also gives rise to the blood supply to the liver. This is the artery that supplies the liver. Fortunately, the body has supplied a basically detour circuit for blood supply. So we could actually remove this tumor with this main artery because there's another artery that comes off of the SMA that runs through the head of the pancreas and up here. So we can do this distal pancreatectomy and remove this artery, the celiac axis, en bloc. So this is what I would call an extended distal pancreatectomy, and I think it's something that more and more surgeons, especially those that have experienced pancreatic cancer centers, are considering as options for patients that in the past were told they weren't eligible for surgery, but in fact can have this procedure. I want to stress that this is a pretty rare procedure as well. In my last 20 years of doing pancreatic cancer surgery, I've probably done about 40 or 50 of these. So you can see that the indications and the time that is important to do this is not that often. There was a recent paper that my colleagues from over in Europe, as well as a few other high-volume surgeons in Japan, put together about who should be eligible for this extended distal pancreatectomy, or DPCAR. And if you go through this flow diagram, what you see is that we think that it was important, again, that the patient not have any distant spread, that it not involve the superior mesenteric artery, and that they have received chemotherapy first. And I think that's an important criteria that we all felt that patients should have. They really, if you're going to do this extended pancreatectomy, just like an extended Whipple, a trial of chemotherapy first, not necessarily to just shrink the size of the tumor, because you can remove all the vessels, but to make sure that that patient doesn't have disease someplace else in the body that would make having this risky, big surgery not potentially curative. The last operation I'll talk about is really only appropriate for benign tumors and some PNETs and for cysts of the pancreas, and that's a central pancreatectomy. This is one that not all surgeons really appreciate or like to do, and I agree with them because it really involves having two cut surfaces of the pancreas, because we really just remove the middle. It's really a rare procedure, but for some patients where you don't want, or it's benign disease and you don't want to lose the entire tail of the pancreas with all of its insulin producing and enzyme producing capabilities, you might do a central pancreatectomy. And so it's just something to be aware of, but I don't think is commonly performed. All right, I want to just spend a few minutes, and I'll move quickly through this part, which is really talk about the role of minimally invasive. I told you I thought the two common sense things that we can do to improve survival are to give chemotherapy first, or to try to make the surgery less morbid. And that's really what the idea of MIS, or minimally invasive surgery. We're trying to take an operation where you have an incision like this and it takes 6 or 8 weeks to recover. And as I showed you, 46% of patients never recover enough to get onto chemotherapy, and make it something like this where there's very small incisions and the patients will bounce back quicker and be able to get onto the important chemotherapy easier. For a lot of reasons, I've focused in on the robot as the way to do this. There's two different ways to do minimally invasive surgery. One is through laparoscopy, and the other is through robotics. When I think about surgical instruments, really the robot is a paradigm shift. It's really something that's changing the game, and I'm going to show you why I think that is. And the reason is this, is because All these other instruments over the history really are just helping the surgeon's hands do a little bit better job, but they're still relying on the skill of the surgeon. They're not really making the surgeon better. They're just allowing him to do things through smaller incisions. The robot, for the first time, puts a computer between the surgeon and the patient. Just like pilots who fly modern jets, they have computers to help them fly those sophisticated jets. That's what the robot, it's misnamed. It's really computer-assisted surgery, and it can actually augment human skills. So I tell people that this robotic platform is no more like a traditional surgical instrument, that the telephone is like a smartphone or a typewriter is like a laptop computer. It really is enhancing the skills. So to go back to that analogy of a pilot, this is what a World War II fighter jet looked like. The pilot flew with the yoke, and he moved this, and it moved flaps on the plane, and the instruments and the weapons that they used could all be done with the human eye and the human reaction speed. But if you're going to fly a modern jet, you need a computer to help you, and it's going to make you a better pilot and allow you to do things that you couldn't do without the enhancement of your skills. And that's why I think pancreatic surgery and all surgery is going to be moving, is towards this computer-enhanced surgery, where we're not using our hands anymore, but we're directing a computer. So I'm going to show you a couple here in a minute, a couple of very brief surgical videos where I really demonstrates why I think the robot is improving the surgeon's skills. So if anybody doesn't want to see or is a little bit hesitant to see actual intraoperative video, you might turn away now, because I'm just going to show two very brief clips of surgery, and there are some blood in it. And the point of this is to show you how the robot is enhancing the surgeon's skills. So here, this is the first thing, which is that's the pancreas, and the surgeon is sewing the pancreas to the small intestines. This is part of that Whipple. I told you, one of those 3 new connections. And what you see is this is a right-handed surgeon using their right hand, which almost anybody could do, even with open surgery, because that's the dominant hand. But then what you see is this is the left hand. Did you see that the surgeon is able to throw using their left hand? And that's what that's what the computer is doing. It's making the surgeon ambidextrous. There's another left-handed throw. So if the angles required are better with the left hand, the surgeon can use the right and left hands just as well, because the computer is smoothing out the motions. Here's another example of that, where we're doing one of these extended Whipples. So we're resecting part of the vein here, and now we have to re-sew that vein back together. So again, I want you to see, this is the surgeon, this is a right-handed surgeon, and they're using their left hand to sew in this graft. Why? Because it's set up for that, and the computer is enhancing the skills. The other thing the computer is doing is magnifying. This is what we call a 5-0 suture, which is like a human hair. You couldn't even see this with your naked eye without magnification. Look how easily the surgeon can see it in the magnified field, and to work with this delicate suture with their non-dominant hand is really an accomplishment that can only be done with the enhancement of the computer. And that's why I'm so excited about this platform as one of the better ways to do minimally invasive surgery. Here's what it actually looks like in the operating room. I thought you might enjoy this. There's the surgeon at the console, and then you come over here. We usually have a surgeon standing right here. I just stepped back from the field so that you could see the arms moving. But what you see is the surgeon is controlling this, and the computer is helping the surgeon operate better. The computer chip is here, and it's allowing them to do those things that I just mentioned to you. And they're controlling the surgical instruments through these joysticks. So it seems almost Star Wars or Space Age-like, but it's here today, and we're doing more and more of these kinds of surgeries. So the promise of computer-assisted surgery, I think, is that the improved surgical skills will lead to better outcomes, decreased length of stay, decreased complications, faster return to health and chemotherapy for our patients, and then hopefully eventually improve survival. And this is just the beginning. The robot or the computers are getting more and more sophisticated. They're going to have ability to put the actual CT scans right over top of the patient's anatomy, so the surgeon really is like a pilot. We'll see the navigation system as well. I'm going to skip over this, this is just what we did in Pittsburgh. We've done over 1,000 cases with the robot, and we've published several papers showing that it's safe and that it's feasible. There's been one trial from Europe now looking at the distal pancreatectomy through the MIS approach, or the minimally invasive approach. This just came out this last month, showing that the minimally invasive approach for the distal pancreatectomy is probably the standard these days. So whether it be done laparoscopically or robotically, having it done through small incisions in a randomized trial showed that there was better patient satisfaction, and better complications. So I think for the distal pancreatectomy, that's really almost the standard of care these days. For the minimally invasive Whipple, there's been a number of studies. This is from a meta-analysis that looked at there was less blood loss with the minimally invasive approach, more R0 resections, better lymph node harvest, and better length of stay in the hospital. So again, increasing amount of data saying that in the hands of the experienced surgeon, that the minimally invasive approach is probably less morbid, meaning less complications for the patient. And this is one from that we did in Pittsburgh in combination with several of our colleagues, where we compared the robotic approach specifically to the open approach, and we were able to look at 1,200 Whipples, both open and robotic, from 8 institutions, and showed that the robotic approach had a little bit longer operative time, but the trade-off was there was a decreased blood loss and a significant reduction in major complications. All right, the last thing I want to touch on is this sort of what I think is really the newer advances in the last year or so of the role of surgery in advanced disease. So traditionally, as I showed you, locally advanced disease is where the vessels, one of these major vessels, are completely surrounded. And we would traditionally think that these are patients that weren't eligible for a potentially curative resection. But there's been a number of papers, this one from our colleagues up at Mass General, that have shown that patients who get chemotherapy, and this one was using FOLFIRINOX, but it's also true of Gemabraxane, the other new chemotherapy, that some of them, even with successful treatment, the CT scan doesn't change. And when they went and they operated on these patients, after they received prolonged periods of chemotherapy with no change in their CT scan, and they said, well, we don't see anything outside the pancreas. Let's see, maybe this is all scar tissue. And that's what they found, is that they could, in almost 80% of patients who had at least 6 to 12 months of chemotherapy and radiation, that some of those patients, even though these vessels were surrounded, it really turned to scar tissue. And the CAT scan looked the same because the tumor was replaced with scar tissue. And so this has really opened up, I think, a new avenue and a new area that we're all trying to figure out, who are the patients that will really benefit with this locally advanced from these aggressive surgeries. And the same group at Mass General has come up with an algorithm that they think in their hands. And I think it's right now every major pancreatic center has got a little different approach to it. But I think the principles are the same, which is at least 4 to 6 months of chemotherapy and radiation to really make sure that the patient doesn't have any tumor outside of the pancreas, and to give the best chance of sterilizing the tumor along those major blood vessels, and then to go to the operating room and do a biopsy. And if you find negative, meaning there's only scar tissue along those vessels, that you go ahead and resect that tumor. And that's a pretty new concept that I think I wanted to share with you today, and I think would be important for some of you to discuss with your practitioners about whether or not this is something that you might be considered. I want to stress that this is something that really probably only should be done at the major experienced pancreatic cancer centers, because it really takes the Whipple operation to a little higher level and can certainly increase the complications if we're not careful. So I'm going to stop there and give some times for questions. What I did for today is review the current state of pancreatic cancer and the fact that we all know we need to make major improvements. I talked to you a little bit about what I, as a surgeon, think about when I think about potentially curable pancreas cancer, and I stressed how I think thinking about surgery first and whether or not we should use chemotherapy first as really the increasing preferred modality. I talked very briefly about the different types of pancreatic cancer surgery, including some things that you may not have heard about, like the DPCAR and the central pancreatectomy and the extended Whipple. I shared with you my experience with robotic surgery and why I think the promise of minimally invasive surgery is something that we can bring to our patients with pancreatic cancer, and it will only continue to improve down the road, and why I am a fan of the robotic approach. And then touch briefly on what I think is one of the major advancements for surgery, which is this idea that some patients with locally advanced disease still could be candidates for surgery. So I really appreciate your time today, and I guess I'll stop there and turn this over for questions.
Thank you, Dr. Zay. we do have time for some questions. The first question is, for a patient who was originally diagnosed with metastatic disease and received chemotherapy that eventually caused all metastases to not be visible on scans, would surgery ever be considered?
So thanks for that question. And, I purposely didn't put that in there because that is a really controversial and I think as yet unanswered question that we don't have a lot of data. So for the locally advanced patients, I think the emerging data is yes, there are some patients with locally advanced disease where the chemotherapy and the radiation can sterilize the area around the vessels. And if they have no distant disease, then surgery is something that can be considered. I do think there are highly selected patients who have small areas of metastatic disease that can be resected at the same time as the main tumor that after chemotherapy can be considered. And in fact, it's something that I don't think is out of the question, but it has to be greatly individualized and really would be important to make sure that it's done and the decisions are made in conjunction with a multidisciplinary team, meaning a medical oncologist and a surgeon and potentially a radiation oncologist. So the answer is highly, highly selected cases. I think it's something that we're starting to think could potentially benefit, but we don't have the data yet to support it fully.
Thank you. The next question is, what training does a surgeon go through to be able to perform robotic surgery, and how long is the training?
That's another great question. Thanks for that question. So that's something that my team in Pittsburgh, before I moved here to UT Southwestern, has thought a lot about. And there are now some programs that we put into place across the country where surgeons can go and get the experience, because this is not a technique yet that's widely taught in the surgical training program. So in 5 years, every surgeon will have been trained on the robotic device, and so this won't be important. But for the surgeons who finished their surgical training before the robot was out, they need to go back and get extra training. And there are a couple of programs now across the country that some early adopters of the platform, like myself and John Martini at the Carolinas, have put out there to help surgeons get the experience they need. And I think that's the most important thing. If you're going to have either a robotic or a minimally invasive laparoscopic Whipple, that you talk to your surgeon and find out what their level of experience is and what kind of training, because probably it's just as important with open Whipple, if you want to know the truth. The experience of the surgeon is really heavily, heavily important.
Great, thank you. The next question is, what stage of cancer, pancreatic cancer, do you recommend for robotic surgery and MIS?
It's a great question. So right now it looks that for the MIS, early on, the resectables clearly, where there's no involvement of the vessels, was our first sort of, I would say, 5 to 6 years of that approach. And then as everything else, as the high volume centers that do this got more comfortable, we've started to do the extended Whipples, which would be appropriate for the borderline resectable category, are pretty routinely approached at the high volume centers with either laparoscopic or robotic approach. So I would say either of those two right now are pretty standard. Now, the locally advanced is something that only the most experienced minimally invasive surgeons are starting to do with the small incisions, and so that's probably the last sort of category, and it's really only a few people who are doing the MIS approach for the locally advanced.
Thank you. A related question is, I have locally advanced pancreatic cancer and have had 6 months of chemotherapy with good results. How can I find out where I might be able to have surgery?
So I think the most important thing is to pick a center that has experience, does a lot of pancreatic surgery, and the more experienced they are, I think the better the outcomes. And so what you're going to find is that the major centers across the country, this concept of even though the CAT scan hasn't changed, that they may be willing to consider surgical exploration. And again, I want to stress that not every patient with locally advanced who goes to the operating room is even resected. The first step is to get it there and do the biopsies and be sure that the treatment has worked as well as you thought it has by doing the biopsies along those vessels. So most important I think criteria in choosing a center is the sort of their volume and how experienced the surgeon in particular is with these approaches.
Thank you. The next question is, with the robotic surgery approach, are there issues with having the surgeon several feet away from the patient? Is the surgeon less likely to be able to intuitively detect how the patient is doing during the procedure? And also, is there a time difference?
That's a great question. So there's always somebody at the bedside. That little video clip I showed you, the surgeon stepped away just so you could see the arms moving. So we do this as teams. There's always an experienced person at the bedside. That was one of the early concerns about robotic surgery, is taking the surgeon away from the bedside. And it turns out that there really wasn't any issues with safety because there's always somebody experienced at the bedside as well. So there really is a team approach. I tell people that the robotic approach is sort of like flying an Airbus 360 to France. There's always two pilots for these long, complex planes, and it's the same thing for these robotic surgeries. So you really have a team, and there's always somebody at the bedside to sort of assess how things are moving along. The issue with the time delay is no, there's really, it's real time. The instruments move. The bandwidth is such that when you move the instrument in the console, it moves real time in the visual field.
Thank you. The next question is, other than tumor location, what other criteria make for an ideal surgical candidate? Nutritional status, family support, etc.?
Yeah, I think it's a great question, and I alluded to early in my talk this sort of nebulous term called functional status, and I think the three things that you mentioned there are all what we as clinicians put into the functional status. I think the common sense issue is that you need to make sure that the patient has the physiologic or the reserves to be able to kind of go back a step in order to get ahead two steps. And so, yes, the family support sometimes plays a big role in that, and as well as the nutritional status. It clearly plays a big role in how well you're going to be able to tolerate the surgery. And we're just starting to understand more and more about how to tweak the nutrition to make it optimal for surgery. And there's things like ERAS pathways that incorporate nutritional supplements that I think are important to consider. Thank you.
The next question is, this participant participated in an SBRT radiation therapy trial recently. Does SBRT disqualify a patient from having surgery in the future?
The answer is no, but most surgeons believe there's an optimal time after radiation, either external beam or SBRT, that's somewhere between 6 and 10 weeks after the completion of the radiation that is really optimal. Having said that, there are select patients, again, on an individual basis, that may have completed radiation therapy in a more remote time period that can be considered for surgery. But most surgeons will prefer for that time period to be somewhere between 6 to 12 weeks, up to 12 weeks, but there is that sort of ideal window to operate on after radiation. But it does not preclude you completely if you're outside that window. You really need to sit down with the surgeon and discuss the pros and cons at that point.
Thank you. And we have time for one more question. Regarding the chemo-first approach, doesn't chemotherapy decrease a person's physiological health so that their suitability for surgery might decrease? Is that a concern?
So thanks for that question. That's a really important point that I probably should have showed a little bit more. Yes, I mean, chemotherapy clearly impacts upon the person, their nutrition, and it can be tough for some patients to get through chemotherapy, and it may take them a little bit of time to get through it. But when we've compared the surgery first to the chemotherapy first approach, a small number of patients fall off, meaning the number of patients who are not able to get to surgery after starting chemotherapy is actually smaller than the percentage of patients who don't get chemotherapy after a surgery because of complications. So when you look at the sum total, meaning the total number of patients who get the benefit of both modalities, it turns out the chemotherapy approach is able to get both modalities more often than if you start with surgery first. So I think it's an important consideration. It's a really great question. And the data says that even though chemotherapy can be tough sometimes, that the number of patients who will get both, and we believe that both chemotherapy and surgery are really important to try to have a chance of getting rid of this tumor completely, that you're going to have a better chance to get both if you do the chemotherapy first approach.
Thank you. We would like to thank Dr. Zay for his presentation. The PowerPoint slides and a recording of this webinar will be available at pancan.org under the Educational Events page. There may be a delay of several days before the information is posted. Your patience is appreciated. A survey will pop up once you leave the session today. Please take a moment to share your feedback. If you have questions, please contact Patient Central at 877-2-PanCAN and ask to speak with an associate. This concludes our webinar today. Thank you.